Nishant, am I audible? Nishant,
Sir, yes, sir.
am I audible?
Yes, you're audible, sir.
The problem is that everything is stopped here in Punjab. Actually, all the Wi-Fi system is only working.
Okay.
Rest is SMS, mobile data, everything stopped.
Okay. So should we begin, sir?
Just will take 1 more minute. Let me sort out the things.
Oh. You can stop sharing, Dr. Monica.
One more minute, Nishant. I will be starting. Huh? Just one. Give me 1 minute.
Sure, sir. Sure, sir.
Monica is there?
Yes, sir. Monica is here, but she's having some problem with the network, sir. I believe some speaker problems.
I think then you can start, Nishant, if Monica has some problem.
Okay, sir. Okay, sir.
You try to arrange all the things in order to start the things.
Right, sir. I just don't have the CVs. Anyways, should we start, sir?
Just let me see 144 people have already. Okay. Good evening, everybody. On behalf of ISA National Headquarters, we welcome you all. And this is basically a revision class. We have already been over with the respiratory system. Now, this is basically required the investigations. They are invariably asked in the examination, either in the practical or in the viva. And next week, we will be touching the short cases. So this week, we will be touching the pulmonary function test so that everything is revised as per the norms and standards of anesthesiology examination, which many of the students will be appearing in the month of May and June. So this class is pertaining to that particular topic. And for this, I welcome Dr. Monica, if she can do the anchoring today, or I request Dr. Nishant to take over from here. Dr. Monica, are you comfortable today or not with your net connections?
Sir, I guess she might be having a little problems.
No problem, no problem. Nishant, you take over from here. You
Right.
start that class and let's see how the thing goes up from that.
Okay, sir. Thank you so much, sir. And a very warm welcome to all the listeners for this ISA online PG classes. Today we have a little hitch because the CV slides are not there. Today we'll be having a very, very important class. As Bajwa sir has mentioned, it will be about pulmonary function tests, and it will be taken by Dr. Riddhima Sharma, who is faculty at LNJP and Maulana Azad Medical College in New Delhi. And the session will be moderated by Dr. Niti. Dr. Niti is in PGI Chandigarh. As and when the time comes, probably towards the end of the session, we'll be putting on their introduction slides because there's been some slight hitch with the internet connections. So over to you, Dr. Niti first, and then with a few words, after a few words from Dr. Niti, then Dr. Ridhima can take over and start sharing the slides. Dr. Niti, can you hear us?
Yes, I can hear you nicely, and I think we are already late by 5 or 7 minutes. So I think let Dr. Ridhima start the classes, and let us not waste more time here.
Yes, yes.
Thank you, sir.
Dr. Ridhima, all the listeners will be muted till the time your lecture is going on. Just in case there are any questions by any of the listeners, they are encouraged to type in the chat box itself. And if you have any questions in the form of MCQs in your PowerPoint presentation, then the listeners are again encouraged to answer those questions in the chat box itself. We will be discussing and I will be assisting you as the time goes. So over to you, Dr. Ridhima.
Thank you, Dr. Nishan. Is I audible to you?
Yes, loud and clear, Dr. Ridhima.
So at the outset, I would like to thank Dr. Vajwa sir for giving me the chance to be part of this ISA National PG classes. I extend my warm regards to the chairperson of the session. As everybody said, I'll be talking about the pulmonary function test. That's a very important topic for the postgraduate, all the candidates, not only for the examination, but also as a clinical part to be a MD after passing this MD. Everybody, you have to check everything, and pulmonary function test is a basic for every patient. So basically, pulmonary function test is a generic term that is used to indicate battery of studies, and that may be performed using standardized equipment to measure the lung functions. So I'll be talking about the respiratory mechanics, lung parenchymal function, and the cardiopulmonary interactions. So why we do the pulmonary function test? There are two basic things. One is to have a diagnostic, another thing is to have a prognostic. For the diagnostic, we have to evaluate the sign and symptoms, including chronic, if the patient is having chronic cough, exertional dyspnea, or screening at high-risk patient, and measuring the effect of drugs on the pulmonary function to assess the perioperative, any risk factors present in the patient, monitor the pulmonary drug toxicity. And it also helps in prognosticating the patient to assess the severity of the patient. If any patient is having any pulmonary complication, and follow up response to therapy, and determine further treatment guided evaluation, and also enable us for the any degree of disability. So TC has given this guideline even 3 decades ago. They are still followed. That consists of if the patient is having age more than 70 years, obese patient, thoracic surgery, upper abdominal surgery, or any history of cough and smoking, or any pulmonary disease, then patient must go this pulmonary function test. But this practically is not possible because it has included almost all the patients, and it costs a very it is costly and time consuming to have a PFT of all the patients. So American College of Physician guidelines have given a very stringent guideline, including any patient who is going a lung dissection, history of smoking, dyspnea, cardiac surgery, or any upper lower abdominal surgery, or any uncharacterized pulmonary disease should go a pulmonary function test, including the uncharacterized means that any patient who's having history of pulmonary disease or symptoms and no PFT has been done in the last 60 days. Coming to the practical advisory for the pre-anesthetic evaluation, the anesthesiologist must balance the risk. All these guidelines are present, but you must balance the risk and the cost of this evaluation against the benefits. And you should always see your patient clinically, what type of surgery it is going, how is invasive the surgery is, and interval from the previous evaluation. Some patient comes to you who has undergone a repetitive surgery and they have already done a PFT, then there is no point of repeating that PFT in a set frame of time. And you have to evaluate the patient of if the patient is treated or symptomatic. So under that, you have to order any PFT if required. So after covering to the indication content, we must know the contraindications, and any patient who has undergone any recent eye surgery or a history of aneurysm, including thoracic, abdominal, or cerebral aneurysm is there, active hemoptysis, pneumothorax, or unstable angina, or a history of recent MI within 1 month is there, then you should refrain these patients undergoing pulmonary function test. So coming to the first category, that is mechanical ventilatory function of lungs or chest wall, we have bedside pulmonary function tests that are generally under evaluated or under rated tests, but they are very important, especially for the postgraduates or the old examiners, and everybody will ask you the bedside PFT. You should know it. And then the static lung volumes and capacity. The static lung volumes and capacity will tell you the elastic recoil properties of the lung, whereas dynamic will tell you the integrity of the airway. And last is the respiratory muscle strength. Then under the category of gas exchange, we have alveolar arterial partial pressure of oxygen gradient, diffusion capacity, and gas distribution test, including single breath nitrous test, multiple breath nitrous test, helium dilution method, and radio xenon scintigraph. Under the cardiopulmonary interaction, it is a very important component of the PFTs. We have qualitative and quantitative. For the qualitative, we have history, examination, and ABG should be done. And for the quantitative, we should have a 6-minute walk test, stair climbing test, shuttle test, and CPET, that is cardiopulmonary exercise testing. So I'll be telling about the a few of the very important bedside tests that you should evaluate, and this will help in the weaning, extubation, and also pre-operative assessment of your patient. The first is that is everybody should know, and we often do in our OTs, the Sebrae's breath holding test. And in this test, you ask the patient to take a full but not too deep breath and hold it as long as possible. If it comes to more than 25 seconds, it means that the patient is having a normal cardiopulmonary reserve. If it is 15 to 25 seconds, it means that the patient is having a limited cardiopulmonary reserve. And less than 15 seconds is very poor reserve, and that might be a contraindication, or you have to weigh the risk of the benefit of that patient undergoing the surgery. So you can relate this breath holding test with the vital capacity. Vital capacity is very important for the patient, and according to the how much time the patient has holded the breath, you can correlate it with the vital capacity. If the patient is having a breath holding time of 5 to 10 seconds, it means that the patient vital capacity is 1500 ml, and 10 to 15 seconds is 2000 ml, 15 to 20 seconds is 2500, and 20 to 25 seconds is 3000, and 25 to 30 seconds is 3500. So as you see, the breath holding time is increased, the vital capacity is also increased. So it is very important component in the post-op period, because if the patient is having the good post-op vital capacity, it means that the less ventilatory support, or the patient is able to cough, and there is less requirement of the post-operative, post-operative complications can be there. Another test is the Schneider's match blowing test. It measures the maximum breathing capacity. So there are certain prerequisites whenever you are doing this match blowing test for the MBBC. First, the patient should be comfortable seated, the chin should be supported, and there should be no air movement. And the mouth and the matchstick level should be at the same level. And there you should ask the patient to open the mouth wide open, and there should be no pursing of lip. After this, the mastic is placed at a distance of 3 inches, 6 inches, and 9 inches. And if the patient is able to blow the matchstick at 9 inch, it means that the MBC, that is maximum blowing capacity, is more than 150 liter per minute. 6 inch, it is more than 60 liter per minute, and 3 inch, it is more than 40 liter per minute. Patients who are not able to blow that, it means that the MBC is less than 60 liter per minute, and FEV1, that is forced expiratory volume in 1 second, is less than 1.6 liter. And if you are able to blow it, it means that MBC is more than 60 liter, and FEV1 is also more than 1.6 liter. Another test that comes is the cough test. You ask the patient to take a deep breath and followed by a cough, and you have to see the ability of the cough strength and effectiveness. Inability to do the cough if the patient FVC is less than 20 ml per kg, FEV1 is less than 15 ml per kg, or peak expiratory flow rate is less than 200 liter per minute. Then the third test comes is the forced expiratory time. After deep breath, exhale, ask the patient exhale maximally and forcefully, and keep the stethoscope over the trachea. So in a normal, if forced expiratory time, that means that the patient expiration will take only 3 to 5 seconds. If it is taking more than 6 seconds, it means that the patient may be having an underlying obstructive lung disease. And if it is taking less than 3 seconds, it means the patient may be having a restrictive lung disease. Another bedside test that we can do is the peak expiratory flow rate, that is done by the right peak flow meter. In this, the patient is blow against this flow meter, and if it is normally in males, it is 450 to 700 liter per minute. There are markings, and that can show the ability to that blow the flow meter, peak flow meter. In females, it is 350 to 500 liter per minute, and if it is less than 200 liter per minute, it means that the patient is unable to cough effectively, and the post-operative period patient may retain secretion and and can lead to the post-operative complications. Another is the De Bono whistle blowing test. This test is not done nowadays, but it used to be done, and it measures the peak expiratory flow rate. In this test, we ask the patient to blow down a white bore tube at the end of which a whistle is attached, and as the subject blows, the whistle is blowing, and leak hold is gradually increased till the intensity of the whistle disappears. At the last portion at which the whistle can be blown, the peak expiratory flow can be seen. This is the de novo whistle, and you might be asked in the examination, this can be kept, or the photo can be kept in the examination to identify. Another thing is the right respirometer, that is directly measures the minute ventilation tidal volume. And this is as you can see in the picture, it is very compact, light and portable, and it can be connected to the endotracheal tube or the face mask. The only thing is disadvantage is that it underreads at low flow rate and overreads at the high flow rate. Another thing, we have a micro spirometers, handheld spirometers are there, and bedside pulse oximetry like monitors are there, which can also measures your pulmonary functions. And last but not the least, ABG. You should always supplement all these tests with the findings of the ABG and correlate it clinically along with all these tests. Now, after talking about the bedside tests, we'll be talking about the static lung volumes and capacities. Basically, John Hutchinson invented the spirometry long well, and it is a cornerstone of all the PFTs. So spirometry is nothing but is a medical test that measures the volume of air an individual inhales or exhales as a function of time. So time is very important. All the measurements are done as a function of the time, and it cannot measure the FRC. The only things that cannot be done with the use of spirometry or measured are the functional residual capacity, residual volume, and the total lung capacity. So there should be some prerequisite for the spirometry. First, the findings can only be correlated when the patient, you have explained your patient properly what he or she has to do. So patient should be sit comfortably, and the prerequisite is you should ask your patient not to smoke or inhale any bronchodilator at least 6 hours prior, or oral bronchodilators should not be taken 12 hours prior. So a patient should not be wearing any tight clothing or vests or dentures, because it may interfere with the findings of the pulmonary function test. And it should, if the patient is very obese or child, so you can also do these tests while the patient is sitting. So you have to put a clip on the nose, and expiratory fix should last more than 4 seconds, and it should not be interfered, because initially when the patient is doing, patient might not use it, understand it, and there can be a coughing, glottic closure, or mechanical obstruction is there. So all these things has to be ruled out before giving the report of the reading this report of the spirometry, because it may affect the patient's treatment. So out of all 3 acceptable tracing, and the largest volume value is used. Apart from all the things, the reproducibility is very important. The test is without excessive variability. So one must see that the 2 largest value of FVC, forced vital capacity, and FEV1 should not vary between the diagonal variation between the 2 tests should not be more than 0.2 liter. So as you can see, that is the first is acceptable spirogram that is showing the peak flow, inspiration, and then there is a peak flow, and then there is a expiration. In the second, the patient had cough, so this type of notch is seen. And thirdly, also there is early termination. And last, there is a glottic closure is there. So all this, you should be able to identify all these graphs by looking at it, and should not accept it for the PFT's value. So one thing is very important in anesthesia, most of the things we do by weight, but the spirometry here we depend upon the height, age, gender, and ethnicity. So height is directly proportional and age is inversely proportional, means as the age increases, the PFTs or lung function volumes and capacities, they decreases. So what if the patient is having kyphoscoliosis or the patient is having scoliosis or draft, then you cannot measure it by the height. So you have to take the arm circumference. So first, I'll be talking about the tidal volume. It is a volume of air inhaled or exhaled with each breath. As you can see in the graph, this is, you can see this is the tidal volume inhaled and exhaled during the quiet breathing. In a normal healthy individual, it is around 6 to 8 ml per kg or 500 ml. Then comes your inspiratory reserve volume. So it is basically a maximum volume of air that can be inhaled from the end inspiratory tidal volume. It is around 3000 ml. And then is the expiratory reserve volume. So it is a maximum volume of air that can be exhaled from a resting and expiratory tidal volume, and it is around 1500 ml. Residual volume is very important, and it is around, it is a volume of air remaining in the lung after maximum exhalation. So you have asked the patient to do exhale maximally, and whatever volume is left is known as the residual volume. It is approximately 20 to 25 ml per kg or 1200 ml. So basically, it is an indirectly measurement of the FRC, that is functional residual capacity, and expiratory reserve volume, but it cannot be measured by the spirometry. Then come to the total lung capacity. So sum of all the volumes, compartments or volume of air in lungs after maximum inspiration, it is 4 to 6 liter. Then comes the vital capacity. So if you see in the graph, if you minus all the residual volume from the vital this total lung capacity, then vital capacity can be measured. So maximum volume of air exhaled from the maximum inspiratory level is called the vital capacity. It is approximately 60 to 70 ml per kg, that is 5000 ml. And vital capacity should be 3 times the tidal volume for the effective cough. So most of the anesthesia drugs decreases the vital capacity, and if the patient is already having a decreased, preoperatively decreased vital capacity, then there can be a chances of oxygen requirement, ventilatory support, or pulmonary complication can be there. Especially our position like Trendelenburg position, the vital capacity is reduced to 14.5%. And in lithotomy, it is reduced to 15%. So you imagine your patient in a Trendelenburg and lithotomy position, how much vital capacity will be reduced. And in left lateral position, it is reduced to 10%, right lateral to 12%, and in patient in the dorsum, it is 12.5%, and prone position, it is 10%. So accordingly, you can measure how much vital capacity can be decreased by only positioning only. Then comes the inspiratory reserve volume. It is sum of inspiratory reserve volume and tidal volume, or the maximum volume of air that can be inhaled from the end expiratory tidal volume. It is approximately 2400 to 3800 ml. And expiratory capacity is the tidal volume plus the expiratory reserve volume. FRC. FRC is the functional residual capacity. It is very important. It is sum of residual volume plus the expiratory reserve volume, or the volume of the air in the lungs at end expiratory tidal position. It is approximately 30 to 35 ml per kg or 2500 ml. So it is decreased in supine position, obese, and induction of anesthesia will decrease the FRC by 16 to 20%. That is why when we are doing the pre-oxygenation, during the pre-oxygenation, we are increasing the FRC and we are increasing the apnea time of the patient. Usually what happens in obese patient or in under the effect of if the patient is having respiratory problems pre-operatively. So the closing capacity is the very important term that you should know. The closing capacity, if reaches the FRC, then the small airway will collapse early and it will lead to the desaturation of the patient. So at the age of approximately 66 upright position, the FRC becomes equivalent to the closing capacity, and at the age of 44, at the supine position, FRC is equal to the closing capacity. Coming to the closing capacity, it is nothing but it is at which the airways in the dependent area of the lung begins to close or stop contributing to the expiring gas. So air trapping can be occur. So one must take care that the FRC should be more than closing capacity. And this is the question that this relation is often asked in the examination about the relationship between the closing capacity and FRC. So FRC telling us, it is telling us the oxygen store, buffer for maintaining a steady arterial partial pressure of oxygen. Partial inflation helps prevent atelectasis and minimize the work of breathing. So as we have already told you that it cannot be measured directly, so it can be measured by the nitrogen washout technique, helium dilution method, and body plethysmography. These are very important, and the short note can be asked on these three methods. You should know it how, at least the principle of how they are measured. So coming to the nitrous washout technique, the patient breathes, in this technique, the patient breathes 100% oxygen and all the nitrogen in the lungs is washed out. The exhaled volume and the nitrogen concentration in that volume is measured. And finally, the difference in nitrogen volume at the initial concentration and the final exhaled concentration allows a calculation of the intrathoracic volume, usually the FRC. Then another test that is comes is the helium dilution technique. In this technique, the patient breathes in and out from a reservoir with a known volume of gas containing a trace of helium. So basically, helium gets diluted by a gas previously present in the lung. And if supposedly we are giving a 50 ml helium is introduced and helium concentration is 1%, then the volume of the lung is approximately the 5 liter. Then coming to the third test, that is body plethysmography. It is derived from the Greek word meaning enlargement. It is based on the principle of the Boyle's law. Boyle's law says that at constant temperature, the pressure is inversely proportional, or the volume is inversely proportional to the pressure. So the principal advantage over other method is it quantifies non-communicating gas volumes also. So this is type of suit is there in which the patient is placed sitting in a closed box with a known volume already. And then the patient breathes with an open glottis against a closed shutter to produce changes in the box pressure proportionate to the volume of the air in the chest. As measurements are done at the end of the expiration, it yields the FRC. Then we have talked about bedside test, we have talked the mechanical test. Now we'll be talking about the static test, and then now we'll be talking about the dynamic lung volumes and the force spirometry. So pulmonary mechanics are used to assess the ability of the lung to move large volume of air quickly through the airway to identify any airway obstruction. So basically, they will tell the integrity of the airways. So in this, we have FVC, force vital capacity, force expiratory volume, FEV1, that is at 1 second of the FVC. Then we have force FEF values and forced inspiratory rates, that are FIFS and MVV, maximum voluntary ventilation. Vital capacity is very important, force vital capacity. It is the maximum volume of air that can be breathed out as forcefully and rapidly. So patient breathes very forcefully and rapidly as possible following a maximum inspiration. So the patient will inspire maximally and then will exhale the air forcefully and rapidly. It is characterized by full inspiration to total lung volume and then going down to the expiration to residual volume. So basically what we are doing with the vital force, vital capacity, we are indirectly reflecting the any resistance, flow resistance property of the airway. So if you see, this is interpretation is done. If it is 80 to 120%, it is normal. And you can see this is a force vital capacity, and this type of graph is seen. If it is 80 to 120%, it is normal. If it is 70 to 79%, then there is a mild reduction. If it is 50 to 69%, then moderate reduction, and less than 50% is severe reduction. Now coming to the FEV1. So if you see, this is a graph plotted against time against volume. This is the forced vital capacity, and FEV1 is the volume exhaled during the first second of the. This is the first second of the FBC maneuver. So it has been said that the 80% of the volume is exhaled in 1 second. So FEV1 is very important to know the integrity of the severity of the smaller airway. It is normally it is 3.3 to 4.5 liter. You can see from the graph it is around 3 to 4. It is falling between 3 to 4 liter. So this is around. Then FEV1. What we are going to interfere, any test that we are going to interfere, we have to deduce certain things that decrease in it will, if FEV1 is decreased, it is decreased in both obstructive and restrictive diseases, and the ratio is generally reduced in the obstructive disease. The one more important thing that we have to know after doing all the PFTs, we should be able to differentiate between the obstructive and the restrictive lung disorders. So if the FEV1 is more than 75%, it is normal. 60 to 75% is mild obstruction. 50 to 59% is moderate obstruction. And less than 49% is severe obstruction. So these are the table, you can remember it. In obstructive diseases, FEC is reduced, FEV1 is reduced, and ratio is also reduced. In stiff lung also, the ratio is normal and rest is reduced, and respiratory muscle weakness, all the parameters FEC and FEV1 is reduced, but the ratio is normal. So as you can see, this is the normal force expiratory curve, FEV1 and forced vital capacity. But in obstructive force expiratory curve, both FEV1 is more reduced than the FEC, hence the ratio is reduced. Whereas in this also, the overall they are reduced, but not that as compared to the obstructive force expression curve. Coming to the force mid-expiratory flow. This is the first second is effort dependent. The middle part of the FEC curve is effort independent. So it will tell you the status of the small airway. It is highly variable and depends heavily on the FEC. So it is defined as the maximal flow rate during the mid-expiratory part of the FEC maneuvering. It is generally measured in liter per second. It is approximately 4.5 to 5 liter per second, or 300 liter per minute. So how it is interpreted? If it is more than 60%, it is normal. 40 to 60% is mild obstruction. 20 to 40% is moderate obstruction, and less than 10% is severe obstruction. Then comes the peak expiratory flow rate. So maximum flow rate during an FEC maneuver occurs in initial 0.1 second. So after the maximum inspiration, the patient expires as forcefully and quickly as he can, and the maximum flow rate of air is measured. So it is usually between 200 to 1200 ml of the FEC. It gives a crude estimate of lung function reflecting large airway function. It is effort dependent, but it is highly reproducible. So you can see that this is a flow meter. It is measured by the peak flow meter, which measures how much air liter per minute is being blown out or by the spirometry. So in normal patient, it is around 450 to 700 liter per minute in males and 300 to 500 liter in females. So clinically, what is the relevance of it? This, if it is the value comes less than 200 per liter, then it means that the patient is going to have an impaired coughing and hence the likelihood of the post-operative complications. As you can see, this is the peak expect. This is the FVC curve. This is FEV1 and peak expiratory force is nothing but a tangent to the steepest part of the tangent line drawn at the steepest part of the FVC. So basically, it is very important. Peak expiratory flow is very important in asthmatic patient, and it is used to identify the severity of the airways obstruction and guided therapy. So it is usually increased in mild, mild to moderate asthma to 50 to 70%, and in acutes where asthma it can be 30 to 50%, and in life-threatening it can become less than 35%. So this is a flow loop in which you see that the residual volume, this is the inspiration, this is the expiration, and the peak expiratory flow is reached. And then this first part is effort dependent, and the second part is usually effort independent. So then comes the maximum voluntary ventilation or maximum breathing capacity. It measures the speed and efficacy of filling and emptying of the lung during during the actually it is nothing but the maximum volume of air that can be breathed in and out of the lung in 1 minute. So basically it reflects the peak ventilation in physiological demands. It is normally 150 to 175 liter per minute, and if it is less than 80%, then there is a gross impairment is there. So you can see this is the graph that is obtained during your spirometry. So subject is asked to breathe as quickly, as deeply as possible for 12 seconds. The time is very important, and then the whole of this plot is measurement is extrapolated to 1 minute. Why we should not ask the patient to breathe fast for more than 12 seconds? Because prolonged hyperventilation can lead to fainting due to excessive lowering of the arterial PCO2 and BICAR. So what does it tells us that MVV is markedly decreased in patients with emphysema, airway obstruction, or any poor respiratory muscle strength. So you can see by this graph that it is the patient is asked to breathe, and then this is the time when the patient is breathing in and out very fast, and then the whole data is extrapolated to 1 minute. So basically, the physiological effect of maximum flow rate can tell you the depend on the degree of effort, that is driving pressure generated by the muscle contraction, that is peak expiratory maximum and PI max, elastic recoil of the pressure of lungs, that is tendency to recoil or collapse opposed by the recoil properties of the chest wall, and airway resistance. Airway resistance is very important, which is determined by the caliber of the airway, and it decreases as the lung volume increases, that is hyperbolic in shape, and high at residual volume and low at total lung capacity. Another thing that is very important is the flow volume loop. It is very important because their examiner nowadays keep that flow volume loops, and you have been asked to identify all these things. So what is flow volume loops? Spirogram graphical analysis of the flow at various lung volumes can be seen. Basically, it is nothing but the graphical presentation. So tracing obtained when a maximal force expression from TLC to residual volume followed by a maximum force inspiration back to TLC is done. So it measures the force inspiratory and expiratory flow rate. It augments spirometry results. And the principal advantage is that it identifies the probable obstruction flow at the anatomical location. So this is a flow volume loop. This is inspiration, starting from here, residual volume, and then going to the total lung capacity. Then there is a start of expiration. Peak expiratory flow is raised, and then it will go linearly, it will come down, and expiration is finished. So if you see the first 1/3 of the expiration is effort dependent, whereas the last final 2/3 of the expiration is effort independent, and it is near the residual volume, the effort is independent. So inspirated curve is entirely effort dependent. This is the inspirated curve. It depends on the patient's effort, and the maximum, there is also one parameter of ratio of maximal expiratory flow to the maximum inspiratory flow. That is one, but this is beyond the scope of this class to discuss that. So I'll be talking about the flow volume loops and detection of upper airway obstruction. So as you know, this is a normal graph in which this is a residual volume, the inspiratory flow increases. This whole is the forced vital capacity, and then you will start the expiration, peak is reached, and then the linear decrease in the expiratory flow is seen. So flow loop basically provide information on the upper airway obstruction, and fixed obstruction is seen usually in the benign strictures, goiter, endotracheal neoplasm, or bronchial stenosis. And it is a constant airflow limitation on inspiration. So if you get a fixed obstruction, you see there is a flattening of both the expiration and the inspiration curve. Because so there is both the inspiration and expiration is affected, and the curve become flattened. Then comes the variable intrathoracic obstruction. You see that there is a, in the intrathoracic, you should always see that there is a flattening of the expiratory limb. So this is a normal limb with inspiration, expiration, but this hump, this top is not there. The peak is not reached. So there is a flattening of the basically expiratory lung. So it is usually seen in observant tracheomalacia, polychondritis, or tumors of the trachea or main bronchus. So what happened during forced expiration? High pleural pressure increases the intrathoracic pressure, which decreases the airway diameter, and the flow volume loop shows a great reduction in the expiratory phase. And during expiration, the pleural pressure around the airway are lower. That tends to decrease the obstruction. So in the intrathoracic, only expiratory limb is usually involved, and there is a flattening of that limb. Coming to the extrathoracic, in which it is usually observed like bilateral and unilateral vocal cord paralysis, vocal cord constriction, chronic neuromuscular disorders, airway burns, or any history of OSA. So in the extrathoracic, you see that the inspiratory limb is involved. So you see there is an inspiration, there is a flattening, the FVC is reduced, the peak is reached, and then there is a linear decline in the expiration. So what happened in that forced inspiration, negative transmural pressure inside airway tends to collapse it. So there is a flattening of the inspiratory limb. Whereas in expiration, there is a positive pressure in airway, which decreases the obstruction, and inspiratory flow is reduced to a greater extent than expiratory flow. So initially we have talked about the fixed obstruction, in which there is flattening of both inspiratory and expiratory limb. In the extrathoracic, you have to remember that there is a flattening of the inspiratory limb is there. So now coming to the obstructive and restrictive lung disease evaluation. The common obstructive patterns or diseases that will be encountered are asthma, chronic bronchitis, emphysema, that is under the category COPD, and cystic fibrosis. So what happened in asthma? If you see that the peak expiratory flow rate is reduced, so that maximum height of the loop is reduced. So you can see here that the peak expiratory flow rate it is reduced, and this is pre-treatment, before any bronchodilator or any treatment has been given. This is the post-treatment, and the third line is the normal one. So airflow reduces rapidly with the reduction in the lung volumes, because the airway is narrow and the loop become concave. You can see this is a concavity is seen, or this is called coving is seen. And concavity may be the indicator of the airway obstruction and may present before the change in the FEV1 or the ratio is decreased. So you can, just looking at the graph, you can see this is the normal one. And this whole of the graph, the whole of the loop is reduced and the peak is also reduced. Then comes the emphysema. You can just differentiate by the flow volume plumes only. There is a coving is seen. There is concavity at the expiratory limb is there. So airway ways may collapse during forced expiration because of the destruction of the supporting lung tissue, causing very reduced flow at a low lung volume and characteristic appearance of the flow curve is seen. So you can differentiate very well see in the asthma, the peak airway flow is reduced and whole of the whereas in emphysema, the peak airway flow is not reduced, but definitely there is a concavity or is there, or that is collapsed during expiration is there. Then coming to the reversibility, it is a very important to see the reversibility in graphs, because that can only predict you the whether your treatment will give benefit or not. In this, what we do, the improvement, we give the patient 200 ml of we give salbutamol bronchodilator 2.5 mg or ipratropium bromide as a nebulizer is given 15 to 30 minutes prior to the patient. And any improvement in the forced expiratory volume in 1 second by FEV1, it is seen if there is 12 to 15% increase in that, or 200 ml in repeated spirometry increase is there observed after giving the bronchodilator. So it means that your treatment, you should treat your patient with steroids. It will help them in the post-operative period. So basically, reversibility is only observed in bronchial asthma. In chronic asthma, there can be a partial this reversibility is there. While in COPD, the airflow is irreversible, although some cases show significant improvement. So you have to weigh clinically whether you want to give, there can be infection or other causes where you can want to give a bronchodilators. Spasm is there, then you can give a bronchodilators treatment preoperatively, intraoperatively in COPD patient. And by the PFT, you can diagnose that whether giving a steroid will help your patient or not, or bronchodilator will help your patient or not, especially if the previous PFT will show improvement of 12 to 15% or 200 ml. So this is very important chart that you should remember, the difference between the obstructive and the restrictive lung disease. If you see in obstructive, the vital capacity is reduced, total lung capacity is reduced because there is decrease in the expiration, there is an obstruction, air trapping is there. So because of that, total lung capacity and residual volume has increased, whereas this ratio is decreased, and another MMFR and maximum breathing capacity is also reduced. Whereas in restrictive lung disease, you see all the three values, including vital capacity, total lung capacity, and residual volume is reduced, whereas the ratio is in normal or increased. So if whenever you get the PFT for your examination, you just focus on these values. First thing you should see is that the FEV1 FVC ratio, it is reduced in obstructive diseases, whereas it is normal or increase in restrictive lung diseases. Then you should see the total lung capacity and the residual volume. Both are reduced in the restrictive lung disease, and opposite is observed in the obstructive lung disease. So this is a normal chart. You can see that FVC and FEV1 equal to or greater to than 80% is normal. In mild, it is 70 to 79%, moderate 60 to 69%, and severe it is less than 60%. Whereas the ratio should be equal or more greater than 70%, and accordingly it has been divided into mild, moderate, and severe. In mild, 60 to 69% is seen, moderate 50 to 59, and in severe, less than 50% is observed. So now we know what is obstructive lung disease, how it differs from the restrictive pattern. So what is restrictive pattern? What we see in interstitial fibrosis or scoliosis, obesity, lung resection, neuromuscular disorder, cystic fibrosis, all these are restrictive lung diseases. It is characterized by reduced lung volumes and decreased lung compliance. So in the restricted loop, you can see that the total lung capacity is seen, low functional residual capacity is seen, low residual volume is seen, and forced vital capacity may be low. However, the ratio is often normal or greater than normal due to increased elastic recoil pressure of the lung. The peak expiratory flow may be preserved or even higher than predicted, leads to the tall, narrow, and steep flow volume loop in the expiratory phase. So this chart is very important. If you see, if whenever you are given the PFT, just assess the ratio. And if you think that the ratio is usually low, then assess total lung capacity. If both of them are low, then see that's a mixed disorder. Whereas in this, when there is a TLC is high, you see, assess the diffusion capacity of the carbon monoxide that will be discussed later. So if it is low, it is emphysema. If it is normal, then it is chronic bronchitis and asthma is there. So this is very important. And if it is then coming to the restrictive lung pattern, you see that assess the TLC. If it is low, it is interstitial lung disease. If it is normal, then chest wall disorders or obesities can be there. So basically, if when coming to the interpretation, low ratio of FEV1 to FEC is obstruction, low total lung capacity is restriction, and when both are low, that it means the obstruction and restriction mixed pattern is there. So, Dr. Nishant, are you there?
Yes, ma'am, you can please start.
Should I ask this? We'll give some time to them now. They can read this PFT, I think.
Yeah, can you please just enlarge it for the audience? They can type the messages in chat box for you.
So if you see, this is a chest X-ray of the patient, and this is the value of the FEC, FEV1, and the ratio is also there. You can see this is a reference. This is the way. This is the way you will get your PFTs in the examination. This is the references. This is predicted, and this is a flow volume loop that we have been discussing. So after that, after reading this, I think in the end we will discuss this. Should I wait for the answer or should I carry on?
Ridhima, carry on, please. We will ask at the end.
Okay. So this is the case 2. You can note the reading findings and you can later on answer. So it's a 32-year animal trainer present with progressive dry cough and dyspnea over the past month. So examination shows generally appears in mild respiratory discomfort. Vitals are temperature 37.2, heart rate 104, BP 135/80, and rest parameter saturation 88%. And fine tecals are present. So you can see the FVC, FEV1 by FEC and TLC is given. So according to the previous chart, if you have noted anything, you can be able to diagnose what type of pattern it is there. And this is a third case, which shows FVC again, FEV1 by FVC ratio, total lung capacity, and the volume loop is there. So by going through this, you can just note the readings, and at the end, if you have any query, you can ask me. And similarly, we have a last case report in which we have FEC, FEV1, and the parameters are there, and flow loop is there, and accordingly, the chest X-ray is also there. Then we'll come to the test for a gas exchange function. So alveolar arterial oxygen tension gradient is very important. It is a sensitive indicator of detecting regional V/Q inequality. So normally you should be able to know in young adult at room air should be 8 to up to 25 mmHg in the 8th decade. And abnormal high values in room air is seen in asymptomatic smokers and chronic bronchitis. So AAA gradient is arterial alveolar oxygen minus arterial oxygenation. So it can be derived from this occasion, from this equation, and usually it is 8 up to 25 mmHg. Diffusion capacity is very important in any of the, it comes as a part of the PFT, especially in patient undergoing lung resection surgery. You should always be able to know that. It is a rate at which the gas enters the blood divided by its driving pressure, and it is the ability of the lung to transport inhaled gases from the alveoli to the pulmonary capillaries. It is normally 20 to 30 ml per minute per ml of Hg, and it depends upon the following three factors principally, that is thickness of alveolar capillary membrane, hemoglobin concentration, and the cardiac output. So it can be measured by a single breath test using carbon monoxide, because patient inspired a dilute mixture of carbon monoxide and hold the breath for 10 seconds. So it is CO ml per minute per ml of Hg divided by arterial minus PC carbon monoxide. So why carbon monoxide? Because it has a high affinity for hemoglobin, which is approximately 200 times than oxygen, and so does not rapidly build up in plasma. So under normal condition, it has a very low blood concentration, almost zero. So when it is decreased in anemia, carboxyhemoglobin, pulmonary embolism, diffuse pulmonary fibrosis, and pulmonary emphysema. Where it is increased in polycythemia, exercise, and congestive heart failure. Then we come to the last section, that is the test for the cardiopulmonary reserves. So in this, we have set of tests that we do. First is a 6 stair climbing and 6-minute walk test. This is a simple test that is easy to perform and minimal equipment. So it will tell you the cardiopulmonary reserve of the patient. So what you ask the patient to 20 steps are taken, and each step is almost 6 inch. So if the patient is able to move more than 5 flights of stairs, that is VO2, that is maximum oxygen consumption is in ml per kg per minute. If it is more than, it is 20, more than 20. So it means that patient has low mortality after pneumonectomy, and FEV1 is approximately more than 2 liter. If patient can climb more than 3 flights of stairs, that it means that low mortality after lobectomy, and FEV1 is more than 1.7 liter. And less than 2 flights of stairs correlates with high mortality, and less than 1 flight of stairs less than 10, whereas 6-minute walk test less than 6 meter, if it is patient is able to walk, it means that VO2 max is less than 15 ml per kg per minute. So at least patient should have a more than 15 ml per kg per minute of oxygen consumption. Then second test we have is a shuttle test. The patient walks between cones 10 meters apart with increasing pace. The patient is asked to walk with its own pace normally, and the subject walks until they cannot make it from cone to cone between the this. If it is less than 250 meter decrease of saturation is observed more than 4%, that it means that patient will have a high risk after any lung resection or any post-operative complication can be observed. A shuttle walk of 350 meter correlates with the VO2 max of 11 ml per kg. So basically, these cardiopulmonary exercise testing are non-invasive, they are effort independent, and to test ability of subjective physiological response to cope up with the metabolic demands. Because what is going to happen, exercising muscles or get energy from 3 resources: stored energy or aerobic metabolism of glucose or anaerobic metabolism of glucose. So in exercise muscle, when oxygen demands increase, so lactate starts accumulating and lactate anaerobic threshold is reached. With incremental increase in exercise, this expired minute of volume, oxygen consumption per minute, CO2 production per minute will be increased. Then after the cardiopulmonary, we have talked about the stair climbing test. We have talked about this shuttle walk test and 6-minute walk test. We'll be talking about the assessment of lung function in thoracotomy patient. I'll just touch this topic. So as an anesthetologist, our goal is to identify patient at high risk of increased post-operative morbidity and mortality, to identify patient who need short-term or long-term post-op ventilatory support. So what will happen when the patient is undergoing the lung resection? It may be followed by inadequate gas exchange will be there, pulmonary hypertension can be there, and incapacitating dyspnea can be there. So you have to see the post-operative FEV1. So basically, what is that? You will there is a formula that is pre-operative FEV1 into 1 minus number of segments of lung to be removed divided by 47. So usually if it becomes more than 40, it means the no or minor respiratory complication is anticipated. If it is less than 40, then likely to require post-operative ventilation, or increased risk of death or complications can be there. And less than 30 is usually non-surgical management should be considered. Then we have post-operative diffusion capacity for carbon monoxide. If it is more than 40, or saturation of more than 90% on air, and FEV1 more than 40%, then it is an intermediate risk. And less than 40 is increased respiratory and cardiac mortality is observed. And in less than 40 in post-operative FEV1 less than 40 means high risk requiring cardiopulmonary exercise tests. In addition to history, examination, and chest X-ray, PFT preoperative evaluation include ventilation, perfusion, scintigraphy, and CT scan, and split lung function tests are also seen. So methods have been described to try and simulate the post-operative respiratory situation by unilateral exclusion of the lung or lobe with the endotracheal tube or blocker, or by pulmonary artery balloon occlusion of the lung or lobe. So by doing this, we will see we will just simulate what will happen after the resection, and we will see how the patient will behave in the post-op period. So basically, it is a 3-leg tool which will assess the respiratory mechanics, the cardiopulmonary reserve, and the lung parenchymal function. So post-operative FEV1 is seen in respiratory mechanism, MVV, maximum voluntary ventilation, and this residual volume and TLC ratio is seen. If it is more than 50%, it means the post-operative requirement of ventilatory support is required, and FVC has been seen. In cardiopulmonary reserve, we see maximum oxygen capacity that should be more than 15 ml per kg per minute. Stair climbing and exercise saturation is seen. If it is less than 4%, then it means that the patient is at a risk of cardiopulmonary reserve. And then a lung parenchymal function can be seen by partial pressure of oxygen more than 60 or PCO2, or diffusion capacity of carbon monoxide. So you can see that, learn this parameters. FVC in abdominal surgery, if it is less than 70% of predicted, and or 2 liter in thoracic, less than 2 liter. FEV1 less than 70% predicted. If it is less than 2 liter pneumonectomy, for pneumonectomy, there is a complication. Less than 1 liter lobectomy, and 0.6 liter wedge or segmentectomy should be seen. Ratio is less than 65%, then there is a high risk of complication. Less than 50% of predicted in thoracic. FEF in 25 to 75%, less than 50%, and in thoracic, less than 1.6 liter in pneumonectomy and 0.6 liter in lobectomy, and then this accordingly, this can also be seen. So takeaway homocysts, all the PFTs and all these tech only act to support or exclude a diagnosis. A combination of thorough history, physical examination, as well as supporting laboratory data and imaging is helpful in developing an anesthetic plan for any patient with pulmonary function. So any question I'm happy to answer. Thank you. Thank you, Dr. Ishaq. I'm done with my presentation. If you want to ask anything, any question, you can ask.
Nishant, take the question from the chat box. There are many questions, and some answers have been done by the students. You can take one by one. Nishant, are you there? Nishant, Dr. Nishant, you're not audible. In the meanwhile, Dr. Niti, you can take up the questions given in the chat box.
Okay, sir, I'll take up the questions.
You go to the chat box, start from the questions there, no?
Yes, sir, there are many questions which have come up to me here. And one of the first questions is why is TLC towards the left in flow volume loops?
Because the patient will breathe from the residual volume and then increase the capacity to the total lung capacity, total lung volume. So it is given like that. First you start inspiring and then you go to the maximum and reach the total lung capacity. So that is why it is given on the left side. Neeti ma'am, is I am audible to you? Is I am audible?
Yes, you are totally audible. That was the question that came in the group. People are encouraged to ask questions on group. Any further questions on group?
I
They
think
want
they have-
answer for the quiz, ma'am. They want answer for the quiz also.
They have answered it for the quiz. I think they want that now.
There are
First case is the obstructive case, obstructive lung disease, in which the ratio is FEV1 to FVC ratio is reduced. FVC is also reduced, and whereas the total lung capacity is increased. The second is also the restrictive lung disease, and the third is very important because in the third you see the all the lung function tests are normal. But if you see the diffusion capacity for carbon monoxide should be seen, especially in the last case, if you see that, if you remember the parameters. So there, this is a case of the pulmonary hypertension because whenever the TLCO is reduced, so it means that that there can be any extra pulmonary disorder is there. And when, should I repeat it or is it okay?
It's not needed.
the next question which has come up is liver grade 3 injury of liver a contraindication to PFT or not?
See, you have to see well, liver grade 3 injury is an emergency. Is there any indication that any PFT, what you are going to do, either you are going to get any benefit? I don't think so. If the patient is having grade 3 liver injury, is going to get benefit from the PFT because it is an emergency surgery first. And second thing is, you are not able to optimize the patient immediately. So, you know, there should be some rationale of doing PFT at that time. Only for the stratification, it is not required. If you think that you can benefit the patient that from this one single line grade 3 liver injury, I don't think so.
Liver grade 3 repair usually comes to you when it is almost, life-threatening condition. At that time, you are more worried about the hemodynamics rather than going for because majority of the pulmonary function tests are elective. So in emergency, what we do, we usually see all parameters which are compromising the hemodynamics. We try to resuscitate those while taking up such cases. So PFT is impractical in such cases. It's more of a life-saving procedure. In life-saving procedure, we don't go for the elective type of investigations. Here, I think a quick assessment on the table with all the available gadgets and resources, you go ahead with that. And the next question is, breath holding is done nowadays. It's still done nowadays,
Yes,
and
it
it's
is still
still a
done.
very crude method, and it's very useful. It is always done, and it has to be done, and very simple during your pre-anesthetic checkup also.
Yes.
You can do the breath holding nowadays. Next question, Dr. Neeti, you just go through what is the next question.
At what distance you start the Schneider match blow test? 25 or
No.
15 centimeter. Ma'am has already answered
No,
that
no.
in her slides, and I think if she would like to repeat, it's 15 centimeters. The next question is, what is EPP or equal pressure point?
Dr. Ridhima, unmute yourself.
When both equal pressure point is a point at which the pressure inside the airways equal pressure outside, that is intrapleural pressure and are equal. So above the equal pressure point, there is a tendency for the airway to collapse, which is opposed by the cartilageous support in large airways and traction by alveolar elastic recoil in small airways. So basically it is when inside and outside equals.
how many parameters can we deduce from cough test?
So basically, the parameters of cough test is a non-bedside test. So one thing very important is the vital capacity that you can deduce by the cough test. So that is important. And second thing is the strength of cough test can tell you the patient is able to secretion, how much it can be able to blow out, because post-operatively the patient needs to cough and take out the secretion. So vital capacity is a very important parameter that you can take it from the cough test.
Apart from that, cough test we can also measure some about things about tell you about silent aspiration and risk for pneumonias.
Yes.
He's asking what is the relation between FEV1 and MBC?
So basically, a maximum in FEV1 is in the curve of the forced vital capacity. If FEV1 is measured in the 1 second, and that is usually usually correlate with your whatever 80% of the expiration is done in the FEV1. Whereas the maximum breathing capacity I have explained already, it is the amount of air that can be flown in and out in 1 minute, and then it is extrapolated to 1 minute. So both of them are like almost FEV1 is in 80% of the expired, and it is 1 minute of the FVC curve.
Like I would like to add something here. Apart from whatever you are measuring airflow obstruction, it is a forced expiratory volume what you are measuring in FEV1. But in patients with obstructive lung disease, as in asthma or COPD, apart from the expiratory obstruction, it doesn't give you about the dyspnea, subjective feeling of dyspnea that the patient is experiencing. So MVV or MBC, it gives you a complete picture. Apart from the expiratory obstruction, it also tells you about the patient's subjective dyspnea or the muscle strength also. So that is all. That is also where it is helpful. So what is the best test in patient having COVID? Another question.
As such, you cannot say that the best test in COVID, but the only thing is that you have to take care that the FEF and the things that can, FEF is you can do FEV1, they are the tests, but depends ki, usually the machines are not disposable. So nowadays we have a finger, this PFTs test and other tests that are disposable, and you can test this depending upon your patient profile. So static test you can do, and bedside tests are better tests, you can do it. But depend what you want to deduce from this PFTs. That is more important.
The question is very vague. The question is very vague. How you define what is the best test in COVID? In what type of patient? In what subset of patient? Whether the patients have suffered from the pulmonary disease during that COVID, or they have some other comorbidities related to the other organ systems. And even if the patient has suffered from the pulmonary diseases, every individual patient is different in different circumstances. Age, gender, then if you go with the radiological investigations, you will see a different picture of the COVID in different type of the restrictive, then obstructive, different patterns you see in all these patients. So you cannot define a single best test in any of the patient. You have to individualize each patient. And definitely we are in the process of forming the guidelines for post-COVID patients also. So that means whenever in future, we will be able to at least demarcate or at least come up with some investigations which should be mandatory in all the post-COVID patients, depending upon the degree of severity of the post-residual effects of the COVID and other features. So you cannot say at the moment, we cannot say that, what is the best test? The best test is the battery of tests which you can do on a patient in an individualized manner so that you can come out with the best anesthesia plan.
Correct.
Another question, what do you mean by normal and abnormal cough test?
No, I think that's not. 6 seconds.
There is nothing abnormal about cough test. It's just that normally what is the strength of the cough and how much effectively you can cough so that you can exclude, take away all your secretion is normal. Abnormal you cannot say, but weak cough or strength of the cough is weak, you can say, but there is no term like you can define abnormal or normal cough test as far as
There are some places where cough test is induced by asking the patient to nebulize and inspire some weakly acidic solutions like citric acid or tartaric acid. So these tests are done, and usually you see the nebulization is of, say, 1% citric acid is given for 1 minute, and you see the number of coughs that are elicited. And it is usually, as ma'am has already told, intraoperative, what ma'am is saying is it is used to assess the integrity of the respiratory muscle strength or the vital capacity, and other asking about cough test specifically, then it is used that induced cough is used to look for silent aspiration and to assess the integrity of the cardiovascular acceleratory responses, like the RR interval is shortened while cough. So these are the diagnostic uses, but operatively for anesthetics, what ma'am done enough. So if you are able to induce a cough in 60 seconds, that is the ideal cough test, and a simplified test would assume the number, would look at the number of coughs in 30 seconds or so.
So means you can tell about the underlying bronchitis or any of the abnormality, you can see it, as ma'am told, these can also be induced. But only thing is that you have to induce the cough, and patient should be able to do the cough effectively.
Another question is MBC equal to 35 into FEV1 is correct or not? So
Yes.
that is just an extrapolation of FEV1 to measure MBC. We have already told you that MBC measures a lot more than what FEV1 does. MBC measures inspiratory as well as expiratory efforts, both of them. FEV1 measures only expiratory, forced expiratory efforts. Ma'am, next question is, how is PFT picture in pulmonary hypertension?
So I think pulmonary hypertension, you have to see the DLCO also. So if it is reduced, then it means that the patient is having extra pulmonary hypertension or extra pulmonary problem can be there. So as in our last that case that I have given you, that shows that the PFTs all are normal, but there is DLCO, that is diffusion capacity for the carbon monoxide is reduced. So there can be a this pulmonary hypertension can be there. So multiple different tests are done, and only thing is DLCO is specific for diagnosing all this pulmonary hypertension and extrapulmonary defects.
Another question is, what is the relation between PEFR and FEV1? PEFR, peak expiratory flow rate, and FEV1. FEV1.
So basically, I have told you that FEV1 is, again, I'm telling the same thing. FEV1 is in 1 second in the FVC curve, and peak expiratory flow is seen when a line drawn tangentially and the peak is reached. This is called, it correlates with the PEF1. So this correlation decreases in patient with asthma or as the airflow diminish. So FEV1 is basically 1 minute of the FVC. And peak expiratory flow is usually the peak reach to the peak reach at the time of this expiration. So you can So basically, it is peak expiratory flow is usually seen to distinguish between asthma patient. As I've told you, it is usually increasing 50 to 70%, and mild to moderate and severe 30 to 50%. And in life-threatening, it can be less than 30%, 35%, like that.
Also, like PEFR measures predominantly proximal airway resistance, whereas FEV1 measures both proximal as well as distal airways, smaller airways also. So I think, can we estimate PEFR bedside?
Peak expiratory as such bedside?
Yes.
No.
You can. You can.
Yes.
Yes,
Dr.
Ridhima, you can.
Yeah, ma'am, you have given now. I think
You can measure with the peak flow meter. You have
Yeah,
got right peak flow meter with which you can measure the peak expiratory flow rate at the bedside.
yeah, ma'am, we have already discussed, I think, in my slide, that peak flow meter.
Yes, it's very easy to measure at the bedside. Even in the ICU, you can measure with the right peak flow meter. Whoever asked that question.
Another person wants to ask, wants you to discuss case 3 again.
Should I, can I
No,
share
no,
this?
don't share the screen. Just go through your slides and then you see the case 3.
Case 3, I find, as far as I know, this the FeV1 and FVC ratio is normal. FVC is reduced and total lung capacity TLC is also reduced. So it is type of restrictive lung disease, moderately decreased, and DLCO is normal. So it means that the extra pulmonary or like spinal cord injury or anything like that. So it is a basically mild restrictive lung disease is there.
Again, next question is in BHT, we have to take deep inspiration or not. So you have to take a like full inspiration, not a forced inspiration.
It's a
And
basic,
with that,
basic
I think
requirement. I think they should go through the books also now.
Yeah.
You are doing a PFT and a basic breath holding time. And you can't take a small inspiration and hold the breath. You have to take a deep inspiration, see your functional residual capacity. That's the way we can, estimate the thing. It's a very simple thing, very much basic thing taught in the books.
I think there are no more questions coming up.
What I suggest here is, I have good suggestions from other seniors here who want to highlight, enlighten the students how to go for the exams or what important other things are left which are not covered in this lecture, so that they can prepare well for the examinations. I welcome all the seniors who are there to give their suggestions to the PG students. Yeah, Dr. Madhuri, you have raised your hand, please.
Yeah, I congratulate Ridhima for a very informative lecture. And as I was going through the discussions which are going on, like as an examiner, we have seen students being asked about pulmonary function test in the table viva. And the main thing is they start trying to diagnose between obstructive and restrictive lung disease. And there only the problem starts in the viva. And then the definitions start on the lung volumes, the lung capacities, and then the examiner goes forwards to management of the cases. So what I feel is that when the student reads the PFT report, he or she also has to go through the clinical profile of the patient. As Ridhima said, the clinical profile of the patient is always to be correlated with the lab report, because there can be many technical issues involved in doing spirometry. In foreign countries, you have those spirometry practitioners and all who do it. Whereas in our country, we just have simple lab technicians doing it, or sometimes maybe pulmonologists will be doing the pulmonary function testing. So whatever it is, there can be so many technical issues which occur during lung function testing, and these should be mentioned in the spirometry report. And whatever result of spirometry will not result in cancelling the case or postponing the case or anything. It will only lead to better management of the case. And one more thing which I would like to add is the Millage and Nunn criteria for the post-operative predicting the post-anesthesia course. So I think all the students can read this, the Millage and Nunn criteria, and it is a combination of spirometry and arterial blood gas analysis, which depends on the FeV1 and the PaCO2 and the PaO2 values on the ABG. Then one more thing which could be added is the split lung function test, like bronchospirometry, which is done in thoracic surgery. I think Dr. Neeti she can elaborate on this.
Ma'am, can you please repeat? Ma'am, can you please repeat the question?
Split lung function test. Split lung function test and prediction of post-thoracotomy pulmonary complications. These two things are also very important. Like the
ma'am, usually if the predicted pulmonary function test, say if the predicted FeV1 FVC is less than 30%, then we can say the patient is at risk of post-operative pulmonary complications. And these tests, I think Ridhima ma'am has already discussed about them. They are usually done if the FRC or DLCO, they are both abnormal. Then only we do perform split lung function test, and we have to decide. There are many ways to decide. One of them that is that there are total of 19 segments, 10 in the right lung and 9 in the left lungs. So we see how much of how many lung segments are resected, and therefore from that we can estimate how many unobstructed lung segments are remaining, and therefore would be able to contribute to the post-operative ventilatory function. So there are many ways. One is the CT guided, one is the fluoroscopy guided. So CT and MRI, they give a good amount of information about the airway, obstructed airways, which have to be excluded from such calculations. There are 3 or 4 methods, but I think this is beyond the scope of more of, I think ma'am has very covered them in very much details. And do you, Ridhima ma'am, would you like to, I think you've already elaborated upon this. Would you like to talk more about this?
Yeah, I think you have already explained, ma'am. It's like
I think ma'am has
want
already
to tell
explained.
something, she can add.
Well, like if both of them are like we measure DLCO and FRC predicted post-op FVC, and if both of them are more than 80%, then we can directly go to pneumonectomy. If it is less than say 30, then we cannot go for pneumonectomy or even lobectomy, and we have to think about lung sparing surgeries. And if it is like equivocal, if one of them is like less than 80, then we have to go for split lung function test, and then we can evaluate whether the patient will survive the surgical, whether the risk, like benefit from surgery is more than the risk of pneumonectomy or lobectomy or whatever is the planned surgery.
Basically, split lung testing is done because the perfusion and ventilation are not same in whole of the lung. So splitly, they will do it integratedly, differently, and they get predicted. So it is a better and advanced test than we do, because post-operative FEV will not include the perfusion and ventilation discrepancy in every portion of the lung.
And when they measure, like one of the measure is with the what I told you is about the lung segments and taking out how many segments, unobstructed lung segments are ventilating. The second, as ma'am has said, is about looking at the ventilation and perfusion mismatch. The perfused segments are only used to calculate the remaining post-operative pulmonary function. There are other methods also, such as scintigraphy, but they're usually not done routinely.
Yeah.
So I think we don't have any more questions, Dr. Niti, do we? No.
No, I think no, there are none.
Yeah, and thank you so much for the elaborate class, Dr. Ridhima. And obviously we can go on for a long time because this is such an important topic. And apologies that we could not share the CV slides to begin with today.
It's okay. I think they should understand that idea of whole classes, that the PG should get benefit, and I hope we are able to justify, and it will help them in their examination.
I'm sure they will, because it has been such an elaborate class that they can check it on the YouTube again, and they can read from the YouTube as and when they want. Dr. Bajwa sir, I think we'll wind it up now, sir.
Yeah, really, it was a revision class basically, because the postgraduate examinations are on the verge, I think, starting in the month of May and June, and the PGs will definitely benefit from all these classes. Moreover, the requests have come for the cases that they want the case presentations rather than the classes for the next, I think, 2 months. So what we'll be doing, on the special request, we will try that we will get the case presentations, maybe long cases or short cases in the coming 2 months. So it will definitely help them in preparation of their examination, because all the senior people will be there to quell the doubts, whatever the PG faces during the viva or during the clinical examination of the patient during presentation also. So we will be getting the best of our teachers, the teachers who have already made a mark in our Indian anesthesiology, who have taken examination for so many times. We will definitely call them to take short cases and long cases, so that student will definitely benefit. And I request all the postgraduate students that to take benefit of this thing, at least try to convey all your colleagues that for the next 1.5 to 2 months, all the classes will be dedicated to the case presentations, and you can give your feedback. You can give your choices also. What type of case presentation you want in priority wise. You can't get all the cases because we will be deciding upon the classes only. You want the cases according to the priority of your examination. So you just send a list to me directly. So we will arrange those case presentation and that will help you. I think most probably it will help you greatly in preparing for the examination also. That's all from my side. And I really thank Dr. Niti Dogra. She has spared her precious time to chair this session and helping our speaker, Dr. Ridhima Sharma, for this class. Thank both of them and Nishant for this anchoring this event. And we hope to meet next week in a case presentation. Till then, from my side, I think best wishes to all the postgraduates for the preparation of their exam. Nishant, final comments from your side and wind up.
Thank you so much, sir. And yes, because it was such an important topic, I'm sure the postgraduates will benefit from the very, very nice talk, Dr. Ridhima, really informative. Thank you so much. And
Thank you, sir.
good night, everyone, sir.
Good night. Good night, everyone. See you next week again on Monday at 6.